Good morning, ladies and gentlemen. Team DentistChannel.online welcomes you to the live webinar. It's a pleasure to have you all today as our esteemed participants for this live webinar. I want each and every one of you to type out your full names and the city you belong to. Come on. I want each and every one of you to type out your names and the city you belong to. Let's have a quick introductory session. Once again, good morning, participants. I request you to kindly type out your names and the city you belong to. Hello, Dr. Natalie, welcome. Dr. Ankur, welcome. Dr. Roy, welcome. Thank you. Thank you, everyone. Thank you for being such a lovely audience. Thank you. All right. That tells me that we are good to start. Well, today is indeed going to be a power-packed Sunday. I say that because of our dynamic speaker for today, Dr. Rahul Vaid. For the ones who know him, are aware about his expertise, his skills, and his passion in dentistry. For those who don't know him, I would like to take this opportunity to welcome and introduce our speaker for today, Dr. Rahul Vaid. He graduated from the first batch of Bharati Vidyapeeth Dental College and Hospital and Pune University in the year 1994. He currently runs a successful private practice at Meerut. He's done his post-graduation in aesthetic dentistry from the New York University, United States of America. He also holds a PG diploma in cosmetic dentistry from Singapore. He's a fellow of the International Congress of Oral Implantologists. He's done his MS in implants from UCLA, United States. He's received his master's clinician certificate in immediate loading implantology from Munich, Germany. He's also a certified teacher of the International Implant Foundation, Munich, Germany, for immediate loading implantology. Dr. Rahul is this one personality that you would never want to miss him. Thank you for joining us, Dr. Rahul. It's indeed a pleasure to have you on our platform on the continuing live dental webinar series organized by DentistChannel.online. We also have with us Dr. Kapil Kalra, who's also a master and an implant foundation teacher for immediate loading implantology. Thank you, Dr. Kapil, for joining us as well. Dr. Kapil would love to answer to all your questions along with Dr. Rahul Vaid at the end of the seminar. Without much further ado, I now welcome Dr. Rahul Vaid to begin with the live webinar on the topic cortico-basal implants, a tectonic shift in implantology. Over to you, Dr. Rahul.
Good morning, ladies and gentlemen. Am I audible to everybody?
Yes, sir. You're audible.
Good morning, ladies and gentlemen. Dear doctors, it is indeed a pleasure and an honor to be in front of you to be presenting this webinar on a Sunday morning. Greetings to all the participants from all over the world. I would like to initially start off with my thanks to the entire Dentist Channel online team, to Siddiq and to Mr. Lobo for having given me this opportunity to share the screen on a Sunday morning. Ladies and gentlemen, it is very kind of you, Mr. Lobo, to have spoken very high words about me. It is so nice of you. I'll try and live up to your expectations. Dear doctors, I am talking on a very, very pertinent, very, very important, and in the post-COVID era, the talk of the town, that is a tectonic shift in implant dentistry, cortico-basal implants, which give us a solution to practically every situation. Ladies and gentlemen, Just to add on to this, to what Mr. Lobo has said, I am a general dental surgeon practicing general dentistry.
Sorry to interrupt you, Dr. Rahul. Could you
Yeah.
please be a little more audible? Thank you very much.
Okay, ladies and gentlemen, I'll just, even though I've been introduced, but I just want to apprise the entire audience that I'm a general dental surgeon doing general dentistry right from 1991 onwards. In my general practice, we do everything right from restorations to root canal, which are our bread and butters, to implants. And implants came across to me in 2003. And that's the time I was introduced to implants. I went ahead to do my MS or a master clinician course from UCLA, which gave me an insight to a different world altogether. I had the likes of Dr. Henry Takai. I had the opportunity to interact with Dr. Sasha Jovanovic, to Dr. Stevan Orban, Dr. Egon. Mind you, ladies and gentlemen, their works were masterpieces. And after having interacted with them, I went ahead to do whatever I was taught and trying to do the best that those guys had taught us. But thereafter, I reached crossroads where the patient expectations came in heavier, and had to do CORTICO BASAL program, which I was introduced in 2008-2009. So I'll just be sharing my experiences with you in the last journey that I have been through this CORTICO BASAL implants and how they have made a difference to me and in my career. Having said that, I always say one thing: it's not the gun, but the man behind it which makes a difference. I'm just sharing my experience. I'm sure there are many other people with many other better modalities of treatments. This is just one modality, and which has worked fantastically for me. And I think it should make wonders for most of us who are in this webinar. My gratitude, my obstinance to our gurus, without whom this journey would never have been possible. And you need a coach for everything in life. It is the coach, it is your guru who gets you from darkness to the enlightenment. My first guru will be my respects to Dr. S.M. Joshi, the gentleman on the right. He has been my principal, my dean, my guiding light, my first guru. He is the one who actually held my hand and is holding my hand ever since. God bless him with a very long and healthy life. Thereafter, Dr. Stefan Hide, who doesn't know him? He is the Jagat Guru, the gentleman who introduced CORTICO BASAL implantology in the way that it is today. So, and of course, my younger brother, my mentor, Dr. Vivek Gaur, he is the one who introduced me to implants and mentoring not only me, but a lot of people worldwide. So my gratitude to these three gentlemen in my life. Ladies and gentlemen, whenever learning is an endless process. We need to constantly keep upgrading ourselves, and we need to have an open mind. I'd like to start my presentation with the quote from the father of our nation. Two kinds of people who never change their views. One, the insane, and the dead. Of course, we're all here with an open mind. I request you to have an open mind and interact with me, see what I have done and how I have managed to, how CORTICO BASAL implantology has made a world of difference to me and in my practice. In my agenda, I will be going through the entire presentation. I will be introducing you to the CORTICO BASAL implantology a bit. I will be dwelling upon the concepts, the rationale of CORTICO BASAL implantology, where they are located, how we do them, various types of implants. I'll be very briefly just touching upon these areas because unless I go into them, showing you cases will not make much of a difference to anybody.
Dr. Rahul, I'm very sorry to disturb you once again. I believe we are having a slight issue with the voice, with your audio. Could we try without the earphones if possible?
Okay, is it now clear?
That's perfectly clear, sir. Yeah.
Am I now clear and audible?
Yeah, you're audible now, sir.
Okay, so I'll be without the headphones.
Yes, please, sir. Thank you very much. Please do continue.
Thank you. So I'll just start off with the agenda once again. I would like to introduce you to the cortico-basal implantology, the concept, the rationale behind it, where they are found in the human jaws, the types of cortico-basal implants that we have, and one question which I want you to ponder right from the word go, and this is something which makes to start your mind tickling, that why alter the bone or the tissue, instead change the implant according to the bone. This is the main crux of this entire presentation. Then I will be talking about the 72-hour loading. Is it a gimmick? Is it a publicity stunt? And I will be telling you about the science behind it, why 72 hours loading needs to be done, and how the bone sets the clock. I thereafter have some case presentations, include some full mouths, some segments, some anterior aesthetic zones, some rather no bone cases, section case, and thereafter I would like to dwell upon 5 main points or some main points that have contributed to my successful, and I'm sure those points or takeaway home messages will work and have worked for all my participants and my friends in a major way. Now, talking of tectonic shift, it is the tectonic shift that resulted in our subcontinent, which was perched up in the icy Antarctica. And this tectonic shift resulted in a total change of process, change of geography, change of thought process, and made it today in the present Asiatic land, making it Sare Jahan se Acha, Hindu se Hamara. So this is the kind of tectonic shift that happened in me and my practice, which I am going to be talking about in my presentation. Now, there are a few points I'd like you to ponder, and I'm sure you'll all agree on that. Patients do not come to us for implants. The doctors, patients come to us for fixed teeth. Implant is just a treatment modality. I'm sure you'll all agree on that. So also, we would all want implant procedures to be very, very simple. Why complicate things? Why make your and patient's life difficult? Root canals are a bread and butter. So all of us would want implant procedures to be simpler than doing a root canal treatment. I'm sure we would all want that. We all want the procedures to be minimally invasive and keyhole surgeries. In fact, in our case, maybe pinhole surgeries. We do not want post-operative discomfort to our patients. And the icing on this is that we want the implants to finish off fast and with good and predictable results and good prognosis. And especially in the COVID era, wherein we would not want too much of an interaction of the patient, doing the best to the patient in the minimum amount of time. But this is our outlook. A lot of our patients would say a no to a dental treatment. Why? Well, I'm sure this is one question which could be asked by all of the patients, and the reasons could be multiple implant surgeries. You need to call the patient multiple number of times, which in the post-COVID era, we need to think about it. We have post-operative discomfort. Even if you're giving a local anesthetic, it is going to cause a bit of a discomfort to the patient. He will require maybe an analgesia for a couple of hours. He'll be slightly numb. So why have all those things? Then we have shortness of time. No, who's got the time to wait for a few months, weeks, times under a year? And of course, we as doctors could be rejecting a few cases. We could have cases where there could be no alveolar bone. We could have cases where the patient is medically compromised and doing your implant surgery could be contraindicated. There could be cases where the patient has got habits, vices. He could be a smoker. And in the Indian context, he could be a pan chewer. So naturally that results in poor treatment outcome. You generally would start rejecting the case. And of course, budget, money will make a difference. So there are just a few points that a patient would say a no to dental implant treatment. Now, how do you convert a no to a yes? As I did my programs in various implantology courses and classes, including UCLA, generally, I was very happy and enjoyed the surgical of the implants. I was very happily doing multiple incisions, doing multiple surgeries. I enjoyed looking at the likes of our teachers doing grafts, the CTs, the ponchos, the pedicles, the bone grafts. Wonderful. They are beautiful modalities of treatment, no doubt about that. But you need to have more armamentarium. You need to have a proper skill, and you need to have a proper patient who would be cooperative to undergo all those procedures. Sinus lift was a new kick that gave us, but that improved and increased our armamentarium. And in spite of all this, when there was no alveolar bone, we were left in a lurch. And invariably, when I began to had a CBCT in my area, I only had OPGs to bank on. And invariably, I would open up the case to do a full mouth and would end up after a couple of hours, maybe 3 hours, suturing it back and saying a no because the OPG did not reveal what was clinically visible. So having said that, that's the time when this tectonic shift, or I was at the crossroads wherein I was finding it to answer all my patients and give them the results that they had come here for. I came across this treatment modality wherein the treatments were practically flapless, practically incisionless, had relatively no contraindications. My inventory came down drastically because there were no grafting materials. There were no other thing which I required to outsource from outside. And I was very happily doing bypasses. And the armamentarium decreased dramatically. There's only one kit that you require. And the icing on the cake, the best part is that you had, when the bone was less, it was an opportunity for you. When a few months back, a few years back, I would outrightly say, put a question mark to my treatment protocol. I was saying a huge yes, a welcome yes. So that was a huge wow factor. So for me, I was at the crossroads, and then two roads diverge in the woods. This is Robert Frost's famous lines. And I took the road less traveled by. And that has made all the difference to me and in my practice. Patients just don't want to rely on slow work. We want super fast cars, buses, trains, planes, super fast computers. In endodontics, dentistry, we are happily giving very, very good results and satisfactory results with single sitting root canals. So, ladies and gentlemen, when life is so simple, why complicate things for us? So, strategic implantology or cortico-basal implantology was a boon for my patients, as well as for all of us, we doctors. Now, what is strategic implantology? It is a science which involves unique crestal and basal implants. I'm emphasizing on the word unique crestal and basal implants because they are unique in a way. I will explain them in my due course. They are with advanced designs in a strategic manner to facilitate the immediate functional loading with the prosthesis within a matter of 72 hours. So I will speak about the uniqueness. I will speak about the advanced designs and how we can immediately load and why we load them in 72 hours. Now, conceptually, this concept was taken, this actually is an amalgamation of an orthopedic traumatology with our conventional implantology. Our orthopedic friends, our orthopedicians for the last couple of centuries have been using polished screws, stainless steel or titanium in material. And they were constantly and regularly bone plating, putting rods and different procedures, putting implants right from the last almost couple of centuries now. And this concept is again an orthopedic and a conventional implant amalgamation. Most of these procedures are carried out employing flapless techniques without any kind of augmentation procedures, grafting, lid splits, sinus lifts, etc., etc. We have various implant systems to various types of bones. We have a classification broadly 3. In fact, now we have a 4th one also. In my presentation, I'll restrict my presentation to only these 3 classifications. We have the crystal implants. These implants are the KOS and the KOS micro series, These are regular crystal conventional implants like them, but they are just monoblock. They have a polished collar, a polished neck, and a polished abutment as well. It's only these kind of implant systems can be used anywhere in good bone cases or where the sites have healed and the bone is adequately present. Thereafter, we have basal or transosseous implants. Now, the first implant that you see here is the BCS or the bicortical screw, as it is called. Now, this is the gold standard for basal implants. This is primarily used in very low or no bone cases because it engages the or fits into the basal bone or the cortical bone, which generally is one of the hardest bones present in the body, least susceptible to infection, highly mineralized and low vascular. So even if there is pathogenesis, it heals fast after taking care of that. These two are the transosseous implants. They are the famous BOIs series. Of late, they have been not in use that much because they involved a lot more invasiveness compared to the other current procedures, which are a lot more conservative in their approach. But having said that, these implants have worked beautifully and have been documented also. Then lastly, we have a combination of implants. Now these implants are used, the first one is called as the BCXES, or in the European countries it's called as the TPG Uno. Now these implants are this implant is a fully polished implant, and it is indicated in all areas, and especially where we have a post-extraction case. It has a longish neck, almost a 4 millimeter long neck, to take care of the bending zone as well, so that it is prosthetically more viable. This incidentally happens to be my favorite, and I'm using it very, very liberally in my practice. Second combination, and this also would condense the bone. This and even the implants, they are known to condense the bone and thereby cause osseointegration faster. Mind you, all these implants that are there, they're of titanium, and you'd all agree that over a period of time, any titanium will integrate with the bone. These initially implants tend to osseofixate and thereafter osseointegrate with passage of time. Now coming on to our last implant, this is a combination of polished, which has got polished fluids in its base. It's got a rough surface in the center. This implant gives you best of both the worlds, best of the cortical engagement and the best of cancellous bone engagement as well. Mind you, all these implants are bendable, and these implants can be used, the rough surface especially, can also be used in anterior segments where you want anti-rotational properties as well. Now, just to give you a very, very brief, very, very primitive insight of how corticobasal and a conventional implant would differ. Now, I want you to imagine a wall, a brick wall, normal brick wall in your homes, wherever, wherein you have a cortex, which is equated to a plaster on one side. On both the sides of the wall, we have plaster, the cement plaster that we have, and in between, we have a lot of brickwork. Now, the plaster work can be compared to or can be simulated to a cortex of a bone, and the inside, the brickwork can be compared to a cancellous bone. This is a very primitive example, just to give you kind of a layman insight as to this is what I show my patients also, so that things become easier for them to understand. So a crystal implant or a conventional implant, the rough surface, unlike this one, the screw will go from the crest and go all the way down till the cortex, till the cancellous area into the bone, into the alveolus, wherein a corticobasal implant will go from the cortical bone into the basal bone, which is the lower part. And if there is plaster here also, it will engage this also. So these implants are relatively longer, they are polished, and they engage a different part of the bone. That part of the bone which is least susceptible to infection, least susceptible to resorption. Why put our money in an area which will resorb, which will go? We rather have things which are safer. So this is a kind of an investment that we do into our patients' bones, into the cortical areas, which are least susceptible to resorption, and they can fight the pathogens better because of the low vascularity and the high mineral content, and heal also faster. Having said that, a crystal implant will lie in relatively less denser bone vis-a-vis a BCS implant, which will lie from the crest and go down from the denser to the densest part of the bone. I hope I'm making things slightly understandable and clear. Now, where they are found? Well, they are found in areas. I will not be wrong if I say they are found in, or we locate them in areas which are non-dental bones. We as dental surgeons don't use them very regularly in our practice. So they are the bones areas like the pterygoids. Rather, we utilize the tuberosity as a portal of entry and engage them into the pterygoid. So they are called as the tubopterygoid implants, or the pterygoid areas, or the pterygomaxillary buttresses. We go into the nasal floor. We go into the nasomaxillary buttresses. We go into the anterior nasal spine area. And we also, to some extent, utilize the floor and the walls of maxillary sinus. Now, these are the areas which are least susceptible to resorption. We all know that the maxilla and the mandible resorb, the alveolus will resorb. So why put our implants in areas which are susceptible to resorption? Instead, why not right from the word go utilize areas or use areas which don't resorb or have minimal resorption? In the lower jaws, they are found in the intraforaminal space. We have crisscrossing of trajectories in the anterior zone between the two maxillary mental foraminas. Is a good cortical bone. Then for most prosthodontists, I'm sure you'll all agree that we utilize the mylohyoid, the distal lingual sulcus. So we utilize the mylohyoid ridge area, the mylohyoid portion in the distal lingual area of the mandible. Of course, the entire length of the mandible on the base. These are the areas where we engage our corticobasal implants and utilize these areas. So it's very important for all of us to be at the right place, that is the strategic position into the basal or the cortical bone of the maxilla and the mandible. We also have the zygomatic areas. I think I missed that? Yes. The zygomatic processes, they are again areas which are least susceptible to resorption. Now coming on to the rationale. I have spoken about this earlier, but I'm again going to reiterate that it is an amalgamation, or we have taken this concept from the orthopedic traumatology. The basal principles are similar to the ones of the orthopedic segments, wherein those gentlemen would be doing cortical engagement. They would be putting their screws through the bone plates to go on to the other part of the cortex, so as to give them excellent stability and create load-bearing areas which were distant from the portal areas of infection in the oral cavity. The cortical bone would get easily repaired after injuries and was less susceptible to infection. The idea of orthopedic surgery or similarity is that orthopedicians also use smooth surfaces. They prefer, or they go in for bicortical anchorage. They go in for non-parallel screws so as to have micro retention in their plates that increases stability against the lateral forces. And bone plates can be simulated to our bridges or rigid metal bridges, which cause splinting, resulting in immediate splinting and immediate loading of implants. So this concept has been taken or amalgamated with the orthopedics and the dental implantology segment. And it is a marriage of these two principles. I've spoken about this, that we have infection-free bone in the basal bone. We have very, very thin mucosal penetrations. I will show you in my cases below. And because of they being polished, there's virtually no peri-implantitis. And preferably our abutments are single piece. We do have multi-unit abutments to cater for people where retrievability is required. And of course, in our implants, we have bending zones as well. So today we are in a position to offer dental implants based on orthopedic principles. So we could also term this particular science as orthopedic dental implantology, wherein we are able to fix teeth to our patients within a matter of 72 hours. Now, having spoken of 72 hours, why the 72 hours? I'm sure this is one question which must have been in everybody's minds. All our colleagues, even our patients, ask that why do you do it in 72 hours, or how do you do it in 72 hours? I'm sure it possibly is a publicity gimmick. Well, ladies and gentlemen, it is not. We are just going by the way the nature wants us to go. We are bound by the nature, and as long as we are in connivance with the nature, things will go our way. So this question as to why 72 hours is because it is the bone which sets the clock. It is not my choice or our choice. It is the bone which demands, so we do it in that particular stipulated period of 72 hours. Now, why this happens? Now, this graph is from a book, Skeletal Tissue Mechanics by Burr and Martin, Starkey and Fry. Now, this is supposed to be a gold standard textbook for orthopedicians and for people who want to go in for osteal study. Now, here we can see there is a vertical line which depicts the quality of the bone, with 100% being the normal, and the horizontal bar shows us the days. So this is a comparison between the quality of bone and the days when the bone is subjected to any stimulus, any insult, it could be extraction, it could be fracture, it could be implant placements, anything. And this is not pertaining to a dental bone. This pertains to any bone in the body. Now this graph, as you can see, moment there is trauma or any stimulus, the first 3 to 5 days, there is a lull. There is no osteal activity. There are inflammatory processes which are going on. I'm not denying that. There is robor, color, dolor, all the inflammatory 5 processes that are going on. But the healing of bone and the osteal remodeling starts 3 days after any bone surgery or an implant placement. So it is within these 3 days that the bone is more stable. It is easily available where there is no osteal activity or it is in good shape. This is the reason why we equip the implants within this short period of time and load them, splint them and load them and leave it in place minimum for 6 to 9 months, maybe longer. These days, we don't need to touch our processes once again. So in the first 3 days, there's an activation. I will give you a small little illustration of with a very, very primitive kind of an animation, which will show as to how we go ahead and how things are done. So this is a normal BMU or a normal bone cell. Moment there is a stimulus could be a trauma, it could be an extraction, it could be an implant placement, any insult, any stimulus. The first phase is called as the activation. Activation means that the first cells, that is the osteoclasts, that is the bone scavengers, the cells which take away the bone, they are the first cells to reach the site of the stimulus or trauma or extraction. They will take around 3 days for them to start activation and to reach the particular site, 3 to 5 days. Now these are moving at a very, very slow, but at a very steady pace of 40 micrometers a day. So first 3 to 5 days, there is total lull. There is no activity. That's the time when we load it. Thereafter, there is a phase of resorption, when just the bone has been taken away. Then for the next 3 days, there is a lull there is no activity at all. The osteoclasts have moved forward and the osteoblasts are kind of forming. 30 days it takes for this thing to happen. Then the phase of refilling. Now the osteoblasts start coming on and they start filling in the space gradually. So by the time the osteoblasts have started off their journey to lay down the bone and the primary mineralization starts. It is, if you see this graph again, it takes 3 days for activation. It takes 30 days for this reversal or the lag phase, 100 days of refilling. It almost would take around 130 days before the primary mineralization ends. Now, this was the time that Dr. Granemark, the father of implantology, wanted to do second stage surgery. That is why the 12 weeks and thereafter process began possibly. But having said that, why go till this particular period of time? The bone is worse than Swiss cheese. Why not load and equip your implants or your bone to the needful in the first 3 to 5 days? In fact, the earlier, the better. So, this is the right time for us is situated 72 hours. The earlier, the better. Now, where do we find or how do we engage these corticals? So, or what are the third or second corticals? Now, if you see this last implant here, the first cortex is the crest of the tuberosity that this implant has perforated. Thereafter, once it exits the maxilla or the posterior part of the maxilla or the tuberosity, that is the second cortex that it perforates. So we have two cortex which have been perforated, and the third cortex is once it engages the pterygoids. So we have a tricortical anchorage in this particular implant. We have a bicortical here. Here we've done a bypass of this particular tooth and engaged the nasomaxillary buttress area, which is again very stable bone. So here we have a tricortical anchorage, and here we have up to a bicortical anchorage. Now, as these implants are minimally invasive, there are minimal surgical complications because you're not raising a flap. I'm sure studies have proven, and I'm sure you all would be aware, that the moment you raise a flap, you end up losing 0.5 millimeters of bone thereafter. So once we are already in an area where we don't want to lose bone, bone for us is gold. We don't want to lose that bone. So why do a procedure that results in even 0.5 millimeters or more of resorption, right from the word go? So we rather go in incisionless. The portals, as you can see in these photographs here, the implants are almost keyhole. This is an immediate post-op pic taken immediately after the procedure. There's practically no blood. In fact, they're relatively very clean. Plus, another question that most of people ask is that why do you have to do an extraction immediately? Why can't we wait? We do an extraction on one side, right side of the lower jaw, then the left side of the lower jaw, then the upper jaw, and so on and so forth, and thereafter plan surgeries thereafter. Well, studies have shown, one of them, Dr. Atkinson was one gentleman who in 1977 happened to have worked extensively on pig jaws, and he proved beyond doubt that whenever there is a trauma or an insult, it is the entire hollow bone which undergoes an osteonal remodeling rather than the particular site. Now, to explain it further, if I have an injury on my skin, say if I have a cut on my skin, it is just that particular skin around that area that will take some time to heal. But for our bones, any kind of an insult, anytime, it will take, as I showed in the previous graph, will take up to a year's time before things come back to normal. So if you're doing an extraction, say in the first 10 days, and you're putting in an implant, say after a couple of weeks, months, you have made the bone, which is sound and stable, into very, very soft bone. And so you're actually trading into murky waters, making things complicated for yourself. So it is best extraction, do the proper toilet of the cavity, ensure that to the best possible way you have curated the area, you've made it infection free, and then you're inserting and loading the implants. So these implants are often flapless, they are keyhole, involving minimum bone cutting. These implants tend to be self-tapping and they condense the bone around the implant during insertion. And being minimally invasive, they are also associated with minimum post-op edema. And the healing at the procedure sites are rapid and often uneventful. Additional surgical risks and complications are eliminated in addition to cost savings. So this actually is a boon to all of us. Now, how do we avoid bone grafting, etc.? We avoid procedures because we are not utilizing those areas. I have bypassed in the upper maxilla, I have bypassed the sinuses, and my implants, or we can even go transsinus because our implants are very, very polished, and the diameter, the osteotomy is 2 millimeters. You just require a 2 mm drill to go through it. And as we are all aware that the Schneiderian membrane can tolerate up to 5 millimeters of an insult or a tear and it will heal. So our implants, this particular implant is 3.6, 3.7 millimeters in diameter. The shaft is 2 millimeters only, and they are monoblock. So we tend to bypass the sinuses or go trans-sinus also easily, engaging those areas which are least susceptible to infection, engaging areas where the bone will not resorb and which is stable bone and will remain stable throughout. Even if the alveolus resorbs or the crest resorbs, the area which is there in the where they are primarily anchored, our implants are osteofixated, which tend to osseointegrate with period of time. For the lower jaws, we utilize the bone around the distal mandible, what we call as the bypass. We tend to go next to the bone. This is the buccal bypass. This is the buccal area, and this is the lingual area. So we've done the buccal bypass. And because these implants are bendable, so they can be bended to suit our prosthetic demands. Here, we've utilized the distal. This is the lingual area. So ladies and gentlemen, why alter existing structures? It could be hard or soft when we have implants designed to suit our needs. So I hope I'm making a point there. So also another rationale is that these implants tend to display 60% less amount of bone compared to any other conventional implants. These are studies which have been done. The bone integrity and perfusion are barely affected. As a result, the post-op swelling or complications are minimal and they have a faster recovery. Another rationale is that they reduce the risk of fibrous formation, they minimize woven bone and promote laminar bone. A laminar bone is something which we are all looking for. So these implants inadvertently promote laminar bone formation. So also it has been shown and studies have proved that the bone implant contact, that is the BIC, was greater in immediately loaded implants. So when we have all these advantages, I'm not saying option B is better than the option 1, no, but I'm just trying to prove what made me scientific as a doctor, as a thinker, think on these lines and start utilizing and incorporating this particular science into my practice. Plus, basal implants work very, very fine and with gum diseases because you're not utilizing the alveolar bone, you're utilizing the cortices. So, and we can immediately, after a proper toilet, after a proper cleaning of the lesion, after liberal usage of antibacterials, we can easily go in for placing these implants. Basal implants, I've already spoken about this, that there are regions are highly resistant to resorption and have high repairing capacities. And of course, various studies, this study as recent as a John Spear study as recent as December 2019 in the prosthodontics conference mentioned that peri-implantitis is one major cause of implant failures, of conventional implant failures. So this happens, there could be many reasons, but one of the main reasons is because they are rough surface. They being rough surface, so they intend to harbor more pathogens compared to a smooth surface. And so the judicious use of monoblock, smooth, polished surface basal implants eliminates the chances of harboring of the microorganisms. Thereby, the peri-implantitis possibility is reduced dramatically to almost 98%. And we can easily use them. There's practically very, very limited contraindications. We can use them in control in smokers, even though a smoker, I would want him to leave the smoking, but, and especially for the first maybe 1 week, 10 days while the soft tissue is still healing, maybe a month, they should ideally leave, but they can be easily done in smokers. In our part of the country where pan is a major deterrent, major vice, so they can be easily used in pan chewers, in patients suffering from chronic obstructive periodontitis, or in patients who have little or no bone. In fact, little or no bone is, as I mentioned, a wow factor for us. You don't require any excessive oral hygiene measures. You just require a regular water flosser or a water pick and a dental brush. And of course, the regular oral hygienes of rinses is all that you require. And once you're doing all this, Money saved, time saved, no additional things into your kitty, no grafts, no second stage surgery, patient doctor interaction is minimal. I'm not saying you don't require follow-ups. All procedures, all dental procedures require regular follow-ups, but then the follow-ups could be spaced in a longish time. So, and in the post-COVID era, you would not want the patient visiting you every now and then. So we have the right stuff. As I mentioned earlier, we have implants suited for each condition. This implant would be there for a post-extraction area. This implant, various areas of various application. I repeat, it's again an operator-oriented kind of a thing, wherein you feel the best. These areas could be in a good bone case. So gone are the days when people would say, "Oh, basal implants, or they are only meant for places where you have no bone." Well, I'm afraid in my practice, I'm utilizing them everywhere. I may be still having an inventory of conventional implants a fair bit, but when it comes to the patient convenience and to my convenience, I have been using these cortico basal implants to the best of my ability and to my patient's comfort and satisfaction. I repeat, what works in somebody's ex's hands may be best for him. I'm by no means saying that this is working fantastically in my hands. This is good, but this has worked and is working and making wonders for me. The last implant that you see here, I would like to mention that this is a MU or a multi-unit abutment implant. Here, I won't be speaking much about these implants, but these just have been introduced recently. And these are the implants where the retrievability option can also be taken care of. So where you think you have a problem, you need to have a solution. And what is a problem for some is today an opportunity for us. For every problem, there is a solution. It's up to us whether we're looking at the problem or we're looking at the solution. So let's make an opportunity out of a problem for people. This is one science which has helped me make that. Now, this is one case I'm starting off with now that I've generally, it's a very huge topic to speak on cortico basal implants. We have a 4 or 5 day course, and yet we feel we're not able to do justice to our participants. So just summing this up in half an hour is difficult, but I've tried to give you a brief insight on the basic concepts of cortico basal implantology. I'm now starting off with my cases. I have tried to cover in my cases most of the cases that areas that would come to us like to a general dental surgeon. This particular case is an HB1AC8. She is a controlled diabetic, a lady in her early 60s. And complaint was that her bridges kept falling off and she was finding it difficult to chew onto things. Now you can see there's almost a roller coaster kind of a processes in the occlusion frame in the upper jaw. This implant, this side, she must have had a cantilever here, which fractured over a period of time. There's a fracture here, as you can see. I'm sorry, the image quality is not too good. So you need to treat the entire case as a whole. Her problem was that she had missing posteriors. She could not chew from this side because there were cracks developing here and the bridges kept falling off. These are radiographs that come across to us every now and then. So after having done all the space work, the entire case as a whole, given her a fresh pair of fixed teeth on either sides, she went in for a zirconium processes. Once the entire area was taken care of, only then did we go in for implants. Implants are elective procedures. They are not emergencies. And you need to follow a proper protocol, need to follow a proper training. This I'm saying from training that I've received from my teachers, from Dr. Shasha and Dr. Vivek and Dr. Henry Tekai, etc. So you need to treat the entire case as a whole. So once she had missing posteriors, we only did work where it was required. I'm a general dentist and I enjoy saving teeth. So I salvaged all the teeth that I could to the best of my ability, did endos, gave her crown and bridge work. Place implants, now this was a good bone case. So I used the KOS micros here. So I happened to have put 3 implants here, practically bloodless. She had a thick gingiva biotype. So utilize that to my ability and to the patient's comfort. So this is a CBCT made in July 2016. As you can see, I happen to have utilized the rough surface implants, crystal implants, the KOS, done a bit of a bypass here. This is the final processes. And this is 3.5-year follow-up. After 3.5 years, things have gone very, very well. She is very happy. She is on insulin these days, but still managing to maintain a decent hygiene. She does have slight amount of materia alba in this area. That's understandable and pardonable. The 3.5-year follow-up this case. And this is a 3.5-year. She happened to have come just before the lockdown, maybe around, I think, January or February. This is a full mouth case. This lady had multiple implants and she was slightly shaky in her confidence. This is a fairly old case. And she had these teeth. She had upper full denture, lower RPD, which was constantly troubling her. And she did not have the kind of patience to wait for a long time. So she came to us. We made an OPG. She had these two teeth which are mobile. So we happened to have extracted all of them. 10 implants. As you can see in the lower jaw, she only wanted the lower jaws first. She was skeptical because she had heard very high or very much of the corticobasal implants. So we went in for the lower jaws first. The lower jaws gave her an upper complete denture. Day 3. And after 3 months, she comes to us back that she's highly satisfied with the lower fixed ones. And there is no comparison to our removable processes. So after 3 or 4 months, she comes to us and gets the upper ones done as well. So we did the upper jaw. This is the post-op CBCT of the upper. Post-op CBCT, immediate after the placement. And this is 5 years follow-up of this case of the upper and more than 4.5. This is almost 6 years now, as of today, as of now. We think that we are in 2020. And she is highly satisfied, eating worthy, and she's forgotten what discomfort meant as far as the dental aspect went. This is another very, very important, very difficult case because a 70, 75-year-old lady and severely resolved pencil thin, rather knife edge ridge. And to make matters worse, this lady was with Parkinson's. So she had a shaky jaw, everything was shaking. So we almost ended up doing 6-handed dentistry because one of my associates was holding the lower jaw, one assistant holding the head to make it stable. And with the pencil or a knife edge ridge, things became more difficult. You can see and appreciate in this, this picture. Very, very thin, practically no ridge at all. So, and the gingiva was very, very flabby. So I had to raise a flap here. So I put in my implants. I put in 8 implants here. And more so because there was a constant movement. So I would the proper purchase point in the bone because of a constant Parkinson's underlying disease. So we place 8 implants. I have utilized the anterior region with KOS micros and the posterior ones with the BCS. This is her final processes on day 3. So from an edentulous to dentate in 72 hours, literally. For somebody who could not chew properly, it is a huge blessing that one gets, when something. She's still got an upper denture on, which requires a change, which hasn't changed subsequently, of course. But this is an old picture. And this is a 1.5-year post-op CBCT. Things are apparently very good. And she herself is very happy because the lower jaws would never stay, the lower dentures would never stay. And at least now she will be coming back shortly. She was to come to us for the upper jaw in May. But I think maybe in due course, once the lockdown is lifted, things could improve and then we could do the surgery for her. There's another case, an old case. This gentleman is an athlete, a huge 6 feet 3, 6 feet 4 inches gentleman, very broadly built. He again was fed up with the lower jaw. So we went in for the lower jaws implants first, Then the upper ones, I'll have to rush through because we have quite a few slides still remaining. So this is post-op, lower post-op OPG. After 1 year, he comes for the upper ones. This is, I think, done in 2013 or 14. And the upper ones, he came to us, I think, in 14 or 15. I'm forgetting the exact date. So these were the implant surgeries. He's a fairly robustly built gentleman. We happened to put 10 implants earlier in the lower jaw because he had a big jaw, and 8 implants. I've utilized multiple implants. I've utilized the BCS here. I've utilized the KOS Plus series here. Of course, the BCS in the posterior and other segments. So it's not necessary that you can just put one set of implants. Whatever works, whatever you feel can give you a good anchorage, whatever you feel a particular situation demands, the bone demands. So you can, according to the bone demand, you can put the implant. Of course, you need to be skilled and experienced for that. You need to be trained to that. These are 3-day post-op pictures, final pictures, post-ops, and this is more than 5 years. I mean, this is almost 5 years when this radiograph was taken. It's almost 6 years plus as for this patient is concerned. Very happy, very satisfied. Another case, practically no bone case. This gentleman had practically no bone, and his lower denture would impinge. As you can see, his mental foraminars had almost gone crystal. So each time he would put on the denture and even come into normal occlusion with the upper denture, he would be in a lot of agony. So this again was a very tough case, difficult case to do for conventional implantology. So here we went in for a buccal bypass. In the previous one, we had gone for a lingual bypass, as I had shown. So we put the anterior regions as the KOS micros and went in for the BCS in the posterior segments. Doing the buccal bypass, this is the process that we delivered, and the smile says it all. This gentleman, another 75-year-old individual, male, again complains of the lower denture and the upper denture, upper bridge is falling off, and the sinus lifts were advised to him elsewhere, which he kind of refused because that would take almost 9 months, he was told. So our initial plan was to just give him a bridge in the lower jaw and bridge on the upper left segment, right segment, and just implants in the posterior left side and the lower posteriorly. But when we removed the bridge, we realized that because of the constant post and core and a lot of dentistry was done, the prognosis of this particular segments is very, very poor. So we decided upon to remove these teeth immediately. We removed them, put implants in the lower jaw. Rest of the teeth, they were these teeth which were salvageable. We salvaged them, gave a bridge. This is very temporaries in the patient's jaw. And then we happen to have done the bridge work where they were required. So these are post-op clinical pictures. You can again appreciate very clean, practically no incision, no blood, and practically asymptomatic areas. This is the bridge that has been given for the bridge here. This is the lower jaw. And this is 1 year after we happened to give him a hybrid processes initially, which was replaced after 1 year with the PFM processes. So this is a 2-year post-op follow-up of the same case. This gentleman is a chronic pan chewer. He's a very well-read person, but pan is something which he can't leave, even though he had promised when we began our surgeries that he had left his habit for the last month or so and would not be continuing. But as you all are aware and must be experiencing it every day, that these kind of patients will never, moment they feel the comfort level is done and the underlying thing is taken care of, they get back to their old vices. So he had a overdenture placed a few years back. This OPG, they were all non-salvageable teeth. Root stumps had gone mobile because there was constant overloading. So we put in these implants here. These methods that you see, ladies and gentlemen, they are various disciplines that we have in the International Implant Foundation protocol. So these are images that I take from my various courses. So they are just there just to give you an insight that they are very, very disciplined. There are 16 disciplines. Of course, this is beyond the preview of this lecture to go in for that. But just to give you an insight, we utilize the method 5A here. We utilize the method 2. So there are different classifications, different disciplines. The impression level pick. This is 1 year post-op pick. Again, the gentleman, in spite of my or his promises, he went back to his pan chewing ways, making life difficult. But in spite of constant stress, this is a 3-year post-op follow-up. Everything seems to be going well. So the CBCT, all implants are in good place. The bone seems to be implants well fixated and doing good without pathology, in spite of all the overloading, that 8 to 10 to 12 hours that he's up, that he's in his mouth. So in spite of, he can take that kind of insult as well. But this gentleman comes to us, gets conventional implants put somewhere. I don't know what the treatment plan was for this particular case. However, his implants were ailing, and he was advised by his dental surgeon that possibly we'll have to go in for removal of these implants. So, and he did not have the kind of patience to go back to him again. So we removed those implants and immediately put in, these are the BCS EX implants, which are to be put into extraction sockets. These are polished areas, polished implants. So I've utilized a combination of BCS. I've done a double pterygoid here, a pterygoid here, and I've engaged the posterior maxilla in this portion. So even though he was advised the lower jaw also was quite compromised, he was advised extraction for the lower jaws as well, but he insisted that the things are not relatively better in the lower jaw. So we gave him a bridge, even though it was with questionable prognosis, but he's happy with the lower jaw fixed with an FPD, with a bridge, and the upper jaw implant supported processes. This is the post-op surgery. This is a post-op surgery. You can see decent healing, and the lower jaw is doing fairly okay. This case is almost now a year and a half, 2 years old. These are post-op pics. I repeat, the smile or the look says it all. He's more than happy. This gentleman is was referred from, rather came from Delhi. He had lower implant supported processes, was very, very unhappy because he had spent almost a year and wasn't satisfied with the lower jaw, and he didn't have the kind of patient to again for that agony. So we removed all his teeth. Here, as you can see, we put an array or multiple implant systems everywhere. I hope I'm making sense to all of you. So these are post-op pics. Again, you can appreciate, even though extractions have been done, things that really about a system is day 3, the patient is made to eat post-cementation. And for somebody who's not been eating worthy for the last years for various reasons, when he or she and has apprehensions that you got put in screws in my mouth, which are fairly long, and you've done so much of jugularity, you've done surgery in the last a day prior to this, and you're making me eating worthy. You loaded those implants. You want me to put pressure on them. You want me to eat. Oh my God, the satisfaction is worth seeing. I mean, your day is made once your patient starts eating food, and you're responsible directly or indirectly for having made added comfort to his life. So what else are we working for as clinicians? These are again post-op pics. Now this is a special case because this was a patient from a very, very low socioeconomic background. This patient was, I was told, this is a consultation case, and the surgeon happened to have called me over that you need to come and do it straight away. I had not seen the patient earlier. This is a patient of mucormycosis who had got a hemimaxillectomy done. And I was told that we needed to do it moment to say it because the patient will find it difficult to go and come back again because of her, for various reasons that she had. So I'm not saying this is the right protocol, but I'm just trying to tell you the versatility with which we can utilize our implants. Now she had, this is her clinical pictures. You can see there is a oronasal, oroantral communication, no maxilla at all. These are her scan views. These are the only ones we sent to me. There's practically no bone here, very thin orbital rim, practically no maxilla, no zygoma. But only thing that was visible was partly, you could see a bit of a pterygoid hanging. So again, another image, there's practically nothing here, very, very thin. So it was a fair amount of a challenge to do this particular case. And having not seen the case, having not known of this case, I repeat, that's not the correct protocol, but this is how this case, you do come out with things which are beyond your control. When you have problems, you need to have solutions. And we got solutions. I happen to have gone in for a flapless zygoma, engaged zygoma here, engaged pterygoids here with my implants. So on 4 implants, I happen to have extracted 1 tooth because her 4, or rather her 2-4 was grade 3 mobile, and she had fair amount of attrition. And this lady is from a very low socioeconomic background, low in education, typical rural India. So this is again, this is flapless zygoma, engaging the pterygoid here and in the anterior region, because she had nothing here to take support from, and she did not want any further extractions. So we gave her a bar on which we put on the processes and gave her an opportunity thereafter. This is 6 months post-op. So she is fairly happy, and the implants have taken up well. This is 10 months post-op. A regular follow-up of all cases is very, very important. Your success in these implants are regular follow-ups and occlusal scheme checkups. I come on to segments. This is a lady who had a Dashanan or a Ravan headed kind of a processes. She had 12 unit processes put on just 4 anterior teeth. And again, the occlusion was a problem. Our lower anteriors had got severely attrited. So we looked into all this case. You need to treat the entire case as a whole. So all these other prosthetic rehabilitations were done. These 5 teeth were found to be treatable. So we salvaged them, did re-endos where required, did endos where they were not done, if it is required, gave a bridge in these processes, gave a processes or a lower bridge in the lower area. I repeat, I'm a journalist. I enjoy saving. I've been trained to save teeth. So I saved teeth that was possible, that was available or possible. I could salvage them. I'm showing this particular radiograph here because it's 4th Feb. This case was done somewhere in 4th February or March 2013. Of course, this particular case was with Dr. Vivek God. The case, this is done. We happen to have salvaged the teeth that was salvageable, given her a lower proper bridge down below, saved the anterior 5 teeth, and placed implants in the posterior maxilla bilaterally where the teeth were missing. That needed to be raised, the bite to be raised. Now this is almost a 7-year follow-up. She had come just recently last year. Now she is a diabetic, on insulins, osteoporotic, and other age-related problem that she's tackling or dealing with. Even after 7 years, things appear to be doing well. This is a 7-year post-op CBCT. Apparently, all good. This implant does appear to be having fair amount of resorption because she's an asthmatic as well, but it's still holding on. And because the other implants are firmly anchored, and this being a polished implant, this can take the kind of load. So no hassles, no problems as far as she's concerned. Now another segment, compromised patient on the bridge. She had a cross arch kind of a missing structure. Only the chewing surfaces were the upper and the lower anteriors. So she had the upper right segment, posterior segment, and the lower left posterior segment missing. We did the other part first. We treated the case as a whole. We needed to rehabilitate this area first. So we did the bridge work and did the implants where the teeth were missing only. There again, I have utilized a combination of BCS EX and BCS. Here a BCS EX and the BCS. These are immediate post-op pics. Now this is another case. This case was referred to me from Punjab. This lady had a severely resorbed area, and we happen to have utilized the intersinusoidal septas here. This is discipline 8B. The pterygoids. This segment, she has been advised that this bridge be replaced, but because she's a consultation and she comes from outside, her dental surgeon has been advised to take care of this segment immediately after. I'm sure by now she would have got these things done long ago. The post-op pic. Another patient. these teeth generally, he's got a lot of dental work done. He's got lower anterior splinted. He's got bridge works all over. Things are not very, very rosy, but he's otherwise comfortable and fine. He only wanted things replaced this side. And after having gone into the other occlusion considerations, we removed these two teeth which are non-salvageable, which are mobile, and replaced them with implants. In implants, you can again appreciate they're almost pinhole, even though these extraction sockets. It's practically very clean surgery. And these being BCS EX, we've taken care of the jumping distance as well, because they have a wider or a broader base here. This is a 1 year post-op CBCT. I'll need to rush through because I'm slightly short on time. There are a lot of cases, and my aim is to just show you an array of where all we can do our implantology, not just in low bone or poor bone cases, but even in regular good bone implantology cases. When you can give things on a platter to a patient in a matter of 3 days, why make the patient wait for a longer time? The question answers, we will be taking them after this, the session, which will be ending shortly. This is an 83-year-old lady. She again had three sides missing areas. She had the fourth quadrant missing, posteriors. She had the second quadrant posteriors missing, and she had a cantilever bridge, which is again fractured. And there was a missing side. So I repeat, we did the entire case as a whole. We did the other parts of the teeth which are salvageable. We crowned and bridged them. Only the ones which were non-salvageable, that is maybe grade 2 to grade 3 mobility, or which had root pieces or had fractured, or where the prognosis was found to be poor, were removed. Bridge works done here. You can see the bridge, the temporary cement is still on. We yet to remove the cement. The implants in place. The post-implant, post-surgery OPG. Again, I used a combination of BCS, EX and BCS. This is a 2-year post-op CBCT of the same lady. Very happy, very satisfied. So it is not just in poor bone cases. Corticobasal implants can be used anywhere and everywhere. That is why the topic itself is a solution for every situation. I once again repeat, I reiterate that this is working fantastically in my hands. So something which works in somebody's hands, by no means I have conventional implantology friends. I have my own conventional implants which I've been doing, which I've done from 2004 and still holding on very, very good. I mean, they are ones which need to be documented. So almost 15, 16 years is a very good time. But this is a new science and has made a world of difference to me and to my patient. So I'm sharing it. Now, this is a patient. We have a lot of patients who come to us who only have posterior missing posterior 6 and 7. How do you replace them? Again, in this case, if you see the reduct, there is pneumatization. Now, we find it very difficult to put a conventional implant here unless we go in for a major, maybe a sinus lift. So here I bypass the bicuspid, giving implants, 3 implants, doing a pterygoid in the posterior most with the BCS EX, and utilize this as BCS. He went in for a zirconium processes. This is his 2.5-year post-op CBCT. This was done in August 2019, the 2.5 years time. So these are his post-op CBCTs, all doing well, all dug well. Now coming on to the anterior segment, again, patient comes to us for teeth. They don't come to us for implants. So this gentleman, a police officer, happened to have suffered a fall, breaking 2 of his teeth. The fall was around almost 3 to 4 months before he came to me. The radiograph revealed fracture of the jaw, and the IOPA revealed there were root fractures as well. So both these they were non-salvageable, and they had to be extracted. They were immediately extracted, implants immediately inserted. I happen to have an immediate acrylic crown because he being so that socially he's not compromised. And this is his immediate acrylic processes. This is almost like 2 teeth in about an hour's time, less than an hour. And this is post-op, 2 years post-op pick. Another beautiful case. This case was walked in, he wanted the replacement of teeth, and the OPG revealed a huge cyst, which incidentally, the cyst was removed, and it turned out to be of inflammatory origin. So we happen to have removed the cyst and done the upper and the lower jaws with bridges, which were salvaged on the digital platform. Even we saved these because these were not mobile and were nice. The patient also did not want too many extractions to be done. So we utilized and saved the anteriors and the upper full jaw, gave him bridges there, gave him a proper occlusal platform, and just the areas which are missing. I happen to have gone in for a polished implant in these areas, even though I had bypassed this entire cystic lesion, which already had begun to heal because the surgery was done 6 months prior to implant placements. We happen to use rough surface BCS, KOS micros here and BCS here. Here I've utilized all 3 BCS because this is a healed case. KOS because this is a healed case. And this is 1 year post-op. You can all appreciate things are apparently very, very good. And the patient has got no complaints. And he's been regularly coming to me for follow-ups every 6 months. This is the case, which is the gentleman is from Jakarta. He was here for a very short while. He had aesthetic complaints and he wanted replacements for his missing teeth. And he was advised extraction of this tooth also. This tooth was not mobile at all. So we thought otherwise, gave him a bridge in this on the upper jaw and the lower jaw because aesthetics also was a major concern for him. Only this tooth was grade 2 to 2 plus mobile and fairly compromised, had a caries lesion as well. This was removed. We treated this tooth endodontically. This is how the clinical pictures were. He has got anterior cross bite, a total collapsed bite. The aim was to replace teeth with implants and to improve his aesthetic to the extent possible. So here we have the bridge, the lower bridge. We happen to replace one side with the lower left side with the implants, and the other side with the bridge. This is the upper jaw with the bridge. This is how he walked in, and this is how he walked out in a matter of within 4 to 5 days. The implants were loaded within 3 days. This is he doesn't stay in India, so he happened to have posted this picture. This is almost a year post-op, 1 year old post-op. He does visit me every 6 months. That's what he's been told. That's one precondition that you need to say. The only main contraindication for me will be maybe a patient who on IV bisphosphonates, patient who is mentally not stable, not willing to take your treatment, who doesn't have control over things, and mainly for somebody who cannot come for regular follow-ups. This is one anterior case. This gentleman, this young boy happened to have lost his tooth, upper anteriors, coming onto the aesthetic zone again, and he had his sister's engagement in the evening. So he was in a dilemma as to how to go about it. So he removed the tooth immediately, the root stump immediately, put in BCS EX implant. And that can be done. I tried to be as atraumatic as possible, but because the root had fractured midway, had to be removed. In the implant, radiographically, this is after the prosthesis placement. Immediately, we gave him an acrylic crown, replaced with the zirconium after 2 days. This is 2-year post-op CBCT. Another case, a young girl, marriageable age, happened to have come to me accidentally because her implantologist happened to have mentioned that there is very thin bone and she will require major grafting, and which will require some time, which she didn't have because she wanted to go in for her marriage. Her folks were after that she gets married as soon as possible. She was a flipper or an RPD wearer. So we put in the implant. Here I have gone for a KOS plus series. This is post-op. Another case, a young girl, rather a middle-aged girl as of now. Her canine was removed, permanent tooth was removed, and accidentally by a dental surgeon, leaving the deciduous behind when she was a child. And the C also happened to have given away a very rudimentary kind of a tooth was remaining. She wanted a replacement for that. In the implant, here I've done the bypass of the lateral incisor, utilizing the nasal floor. Fairly decent aesthetics, even though there was scarcity of space. It was a C which was missing, and the teeth had moved in the because the tooth was extracted. She was very young, and this lady is around in her mid-30s today. So 1 year post-op CBCT. You can appreciate the bypass. It seems to be going very close to the lateral, but not touching or hugging it. If by any chance had I touched the tooth next to it, there is a technique. There are very sensitive procedures, so you need to be properly trained before you embark upon these procedures. Another case. This is a patient, young girl, failed grafts. She had got grafting procedures done twice, but unfortunately they never took up. This was done in 2000, 5 years back, I think 2015, maybe before that. So we put in 2 implants in this region, PCS implants, engaging the nasal floor. This is how she came after the implant placement. Again, you see very neat, very clean surgery, and this is after the process is in place. And this is almost 4.5 years post-op follow-ups. So things well in place. Patient highly satisfied. Now, ladies and gentlemen, now that I've spoken about most of my cases, I've tried to dwell upon most of the areas. I have not gone in for any hi-fi or any specific cases which are not. These are cases which generally walk into your clinic. I have a battery of cases. I have placed thousands of implants, but these are the cases which generally would walk into our clinics. And as general dental surgeons, this is the option that I have given to my patients. And in a matter of 3 days, once you can give this particular opportunity to the patient, that in 3 days, the patient is going to be eating worthy with minimal discomfort. So why not give this an option? Having said that, everything is not as rosy as it seems, or maybe as somebody could have taken it. We all have complications. Everything comes with 2 aspects of the coin. There are some complications in cortic visual implantology. There could be many, but just to name a few, we have some interoperative. There could be bleeding, that is nasal bleeding or nasal discharge. There could be pain, of course, associated intraoperatively. There could be cortical bone, which could fracture because, again, the operator not being that trained, or at times inadvertently, even an experienced hand could result in cortical bone fracture. There could be fracture of the implant. There could be improper bending related complications. There could be an oroantral fistula or oronasal fistula. Now, having said that, you need to be trained before that to handle all these things. You must know how to handle the complications much before you embark upon any procedure. That goes without saying for anything. There could be immediate post-op complications, which would include bleeding, pain, improper seating of the implant-supported processes. There also could be, in some cases, inferior alveolar nerve paresthesia, which could be short-term or long-term, or at times, very, very rarely, unfortunately, in case you are unlucky and have done a blunder, a permanent thing also. There could be a temporomandibular joint pain. The implants could go mobile. You could again fracture an implant post-operatively. The patient could bite onto them. There could be infections. There could be impaired chewing efficiency because of various reasons. And of course, trismus or restricted mouth opening. Delayed post-operative healing could be complications, could be pain, mobility of the processes, fracture of the implant, fracture of the bone, infections. There could be sterile loosening because of overloading. There could be impaired chewing efficiency. There could be many more, just to name a few, just to enumerate a few that came up to my mind. And the reasons for complications also are many, but just to enumerate, it's very easy to see the wrong thing, but why? Everything requires a proper treatment planning. Before that, we all need to be properly trained. It's not a cakewalk. And learning is an endless procedure. You need to keep adding to your knowledge, keep learning. Each case makes you a more experienced person. Each case teaches you. I'm sure you all would be coming across, oh, it's a very simple endo to be done. Once you start opening it up, you realize that things have become difficult. It's not all that easy. So each case will teach you, and you have to be the treatment plan has to be done very, very meticulously. You need to make pre-op impressions. You need to see the radiographs, maybe take a CBCT if required, analyze it, assess it. Then you need to treat the entire treatment as a whole. You need to tell the patient, apprise the patient that if you don't do this, if you only treat one side, you will end up jeopardizing the other side and this side, because you will be inadvertently overloading the entire area, resulting in the treatment failure. There could be adequate knowledge, lack of adequate skill of the operator, experience of the operator, improper armamentarium. In our case, armamentarium means these you should have all types and sizes of implants, which is very, very necessary. Then lack of proper lab support, improper fabrication of the processes, wrong material that are used, then delay in processes. As I mentioned, if you don't do it in 5 days, things thereafter start becoming difficult. The bone starts behaving like Swiss cheese. So your prognosis end result starts to vary thereafter. You could be not cementing or luting the processes well. Most importantly, dentistry, entire dentistry, I would say, is directly proportional to occlusion. Your occlusion scheme is good, things will work out. So your incorrect occlusion scheme could be a major reason for a failure or a complication. You need to have regular 6 monthly checkups and follow-ups and do occlusion adjustments regularly, which includes radiographic evaluation at least once, I would say twice a year, initially, at least for the first couple of years. So irregular 6 monthly follow-ups. And of course, you need to go in for overload processes. You by no means should be overloading and have a regular follow-up. Follow-ups, I repeat, are very, very important. Now, I would just like to recapitulate the entire thing. The cortico-basal implants, especially in the post-COVID era, they give you keyhole surgeries. There is immediate functional loading within 72 hours, which includes no bone full mouth cases. You do not require to augment bone in our systems. There are a wide variety of designs available to suit different types of bones. Bone need not be modified. Instead, the right implant design may be chosen to for the particular bone that is available there. There is post-op discomfort is least, relatively lesser complications, and it works fairly well in smokers as well as in controlled diabetics. So, ladies and gentlemen, all implants, I would equate them or simulate them with the motto of the Olympic movement, which mentions Seatus, Altius, and Fortius. That means faster, higher, and stronger. Our implants can be loaded a lot more faster, that is Seatus. Altius, that is with higher patient satisfaction, and stronger, with stronger torquing forces. So having said that, I had mentioned about the takeaway messages, ladies and gentlemen. We need to strengthen our basics in a big, major way. And you need to keep reading, keep taking courses. Basics, something which are, or the fundamentals is something which are very, very important. The more you clear your basics, the stronger you become in your outlook. You need to treat the case as a whole, very important. Document all your cases very, very meticulously. In the medical legal era, in the arena that we face today, we need to document your cases very, very well. The best part about this is from start to finish in a matter of 3 days, or at the most 72 hours. But there's a disclaimer to that. The follow-ups or regular intervals are pertinent, are most important. Then this system has got a unique, immediate functional loading system. I repeat, immediate loaded, yes, but immediate functional loaded. Your patient is eating worthy right from the word go. All you need to wait, you just need to wait for the cement to set. You could wait for half an hour, depending upon the cement that you've used, depending upon whatever you use, and the patient is eating worthy. Because of all these reasons, you have the best patient conversion ratio and best returns to us dental surgeons in terms of finances, and the icing on the cake. What better for a dental surgeon to come to you with this? That is the best thing that you can have. I'd like to conclude the way I began, ladies and gentlemen, with the quote from the father of our nation. First, you be ignored, then you that. You'll be fought with also, and then ultimately you win, because your cases make you win. So doctors, The right place is in the cortices. The right time is 72 hours. I've already mentioned, and with the right person. So it's always best to be at the right place at the right time with the right stuff, and it is you, the cortical basal implantologist, who is the right person. So having said that, ladies and gentlemen, I'm very, very thankful to all who have patiently stayed there on a Sunday morning and heard me. We are a team of 3 people who take regular courses. We have Dr. Neelam Maheshwari, who hails from Jaipur, and Dr. Kapil Kalra. Both of them are teachers, IF teachers and IF masters, and we've been conducting innumerable courses, done innumerable participants who have benefited from us. I'm sure some of you would be a part of this webinar as well. So just a small little insight into the TriCords team and our various courses, just a few glimpses of how we do. We've been conducting cadaver, and a lot of our participants have benefited. It's a 4-day program held in various parts of the country. This is an image from the iPod. A lot of happy participants. So this science needs to be, it's pertinent that you all undergo good training, get yourself well appraised with the different systems, and then go in for this particular system. It's a unique system, but training is a must. And I repeat, it's not the gun, it's the man behind it that makes the difference. So it is you, the dental surgeon, who is going to make the difference and make this science and your life comfortable for your own self. So please feel free to contact us. This lower is our TriCords Facebook page. Please feel to join this group, and I am ready to take any questions. I do have Dr. Kapil Kalra with me, who will be joining me in taking your question and answers. Thank you so very much. I've been very, very grateful to all of you, especially to Dentist Channel Online. And I would now like to request maybe Ruben to take on the question answers, if at all there were any, from the participants.
Thank you so much. Thank you very much, Dr. Rahul, for the excellent presentation and for the wonderful clinical cases that you've presented. Friends, I'm sure each and every one of you have enjoyed the presentation. I thoroughly enjoyed the presentation. If you did, I want you to mention that the presentation was wonderful, fantastic, or excellent. You can either use one or you can use all 3. Excellent, fantastic, wonderful. Come on. I want all of you all to kindly mention in the comment section that the presentation was fantastic. It was wonderful. It was lovely. You can mention all that you wish to. Thank you. Thank you very much. There you go, Dr. Rahul, with the array of excellent thank you messages that we are getting. That shows how beautiful the presentation was. I think, Dr. Rahul, you would need a quick 2-minute break. And in the 2-minute break, I would like to give everyone an insight on dentistchannel.online. So I request you to kindly stop your screen share for a moment.
Yeah.
Thank you, friends. Thank you so much. We feel so nice to receive your excellent, your wonderful messages. Thank you so much. Keep supporting us. That is all that we wish to. Thank you very much. Friends, you all have close to 2 minutes of your time now to note down each and every question. You can note down, you can mention any of your questions. We have Dr. Kapil Kalra, a master in immediate loading implantology, as well as Dr. Rahul, a speaker himself, who would love to answer to all your questions. Thank you very much. Thank you, friends. Thank you very much for your lovely messages once again. It's so nice that you all were participating in this lovely webinar. And a big thank you to Dr. Rahul for the houseful webinar that we had today. All right, friends. Here's a little bit about our team dentistchannel.online. As most of you all know, we are a dental media company, and the live webinar series, the continuing live webinar series, has only been possible because of y'all, because of your enthusiasm, and because of the participation that we've received from each and every one of you. Thank you very much for supporting dentistchannel.online. Keep supporting us. keep mentioning all your feedbacks. We would love to have all your feedbacks. Do like, share, and subscribe to our YouTube channel, to our Instagram channel, to our social media pages, so that you can stay in touch with us, so that we help you to stay in touch with the entire dental world. Please do subscribe to our channel, dentistchannel.online. You can find us on YouTube, you can find us on Facebook, and you can find us on Instagram as well. Here's our official page. We are called www.dentistchannel.online. We have an array of scientific blogs, presentations, clinical cases, etc. You can go through them. You can widen your knowledge on any and every aspect which is there in dentistry. From implantology to digital dentistry, there's everything in store for you in www.dentistchannel.online. Please feel free and please do visit our website. Once again, like I mentioned, please do follow us on our social profiles. We would love to stay in touch with you, and we would love to give you the best we can from the world of dentistry. An e-certificate of participation for today's webinar would be only given to you upon your request. I repeat, an e-certificate of participation would be only given to you upon your request. For that, you need to mention your full name and the name of the webinar on the below mentioned WhatsApp number. I repeat, an e-certificate of participation would be only given to you upon your request. For that, I request you to kindly mention your full name on the below mentioned WhatsApp number. It's now time for me to tell you about the very important webinar, which would be taking place today at 3:30 p.m. Indian Standard Time. You cannot miss this webinar. We have a very special speaker. He's Dr. Ritul Agarwal, who's also a world's top 100 doctor in dentistry awardee. We are very happy and we are very privileged to have him on our platform. I'm sure you all would not want to miss this live webinar. Please do register for this webinar. Instead of Netflixing and chilling, you can watch this webinar and you can widen your knowledge. Please do register for the webinar. This is webinar number 2 for today, Sunday, 17th May, 2020 at 3:30 p.m. Indian Standard Time. You can find the link to this webinar in the chat box. Thank you very much, Dr. Rahul, Dr. Kapil. And it's now time for us to start with the most important session, the live question and answer session. Dr. Rahul, if you're ready, we would like to start with the live question and answer session.
Yeah.
Thank you very much, sir. We're starting with the first question, a question from Dr. Aparna Mari. Kindly give a note on the 8th discipline.
Okay. Now the 8th discipline is, I would like to define it. It comes in two parts, 8A and 8B. It is placement of apical threads of the implants into the cortical floor of the maxillary sinuses for anchorage. Now, one would say maxillary sinus, how is it possible? Well, we do have fair amount of palatal cortical bone available. Now, I'll give you a small little simile. When we do the extractions of the upper sixes, the palatal root is the thickest and the bulkiest. There is fair amount, and in case of a palatal, in case of removal of sixes roots, we find the the palatal root to be the toughest to extract. So that means there is fair amount of thick cortical bone around that area. So that is the area that we utilize to put in our implants there. Even though the 8A says that, the 8B would say into the intersinusoidal buttresses. Now these buttresses are again very, very nice and strong cortical bones. So I hope that answers your question.
Thank you very much, sir. Moving on to the next question. This is a question from an anonymous attendee. What are the contraindications in screw retained?
Screw retained, as in screw retained processes.
Well, so that's not really mentioned.
Look, anything which is, I'll give you a small little example. When we do a full mouth bridge work or an anterior bridge work, say a 5 unit, say a 6 unit, canine to canine, we do not go in for a screw retained or a removable processes. Screw retained is, yes, you have the retrievability option that should you want to remove or retrieve the implants tomorrow for any reason, you can do that. But that comes with a problem that a screw retained is in another joint interface. So chances of screw loosening, chances of screw fracture, chances of pathogenesis accumulating in that joint in the interface could result in that. So there are many, but it again depends upon the dexterity of the clinician as to how he or she is going to manage that. So that is where these implants, because they are monoblock, they are single piece implants. That is where the screw retained things don't make an ingress here. Even though we do have public demand, the International Implant Foundation has come out with an MU implant system, wherein you could want to retrieve it for some reason, you can have it that way.
Thank you very much, sir. Moving on to the next question. This is a question from Dr. Mahi Singh. What is the post-op care in order to maintain longevity in immediate implants?
Regarding the cortico-basal implants, you need to have a regular follow-up, both radiographic and clinical follow-ups. In fact, I would call it a relative contraindication. If my patient cannot come for a follow-up, I would not take up that case. This happens more so in patients who are coming from overseas. So while I do a case, I would want them to be there for at least 15 days to a month's time. I would not be calling, I would be calling them possibly only after a fortnight or maybe before they leave. But a regular follow-up of patients, a regular radiographic analysis, a regular occlusal analysis. You need to do constantly occlusal checkups, because over a period of time, patients could become, could start chewing unilaterally from one side for any reason, resulting in overload of that particular side and underload on the other side. So the knowledge of the basics that I mentioned in my takeaway message are very important. So you need to have the basic knowledge, and you must ensure that follow-ups are very, very important. Dr. Kapil, you want to add something to this?
Dr. Kapil.
Add something to this, Dr. Kapil?
Yeah, actually, according to me, the question was regarding what all hygiene maintenance are required, like for the patients. Yes, you are absolutely right. Regular follow-ups are required, but in this system, we are doing the self-cleansing processes. That means the processes is having a buccal flange and not the palatal flange. And there will be adequate space for saliva to go and reach there and clean the prosthesis by itself, or patient can clean it by its tongue or with the help of different intraoral flossers and all these things. So hygienically that can be maintained very easily. And as our implants are highly polished implants, so in the long run there are very few or rare chances of periimplantitis. So talking about that aspect, that how to maintain it hygienically, so our implants are safer and patient never complains, because in anterior region we keep buccal flanges, and in posterior region we keep the prosthesis very sanitary, at least 2 to 3 mm away from the gums. So anything which will go and come out, like in cases of periodontal surgeries, there is a self-cleansing space. The food goes there and it comes out by itself, or when the patient rinses. So
if
that's
I may
what I
sum it
wanted
up,
to add.
all you need to do is proper rinses, maybe a water flosser or a water pick, and an interproximal or interdental brush. That should suffice.
Thank you very much, sir. Moving on to the next question. A question from Dr. Mohanji Pandey. How to overcome the complications of IAN nerve lateralization or transportation? Is it required for cortico-basal implants?
Could you repeat the question once again, please?
Sure, sir. This is a question from Dr. Mohanji Pandey. How to overcome the complications of IAN nerve lateralization or transportation? Is it required for cortico-basal implants?
No. Why?
I would like to answer.
Yes. Why do you have to lateralize the nerve at all? Once you can utilize the bone that is available buccally or lingually, you don't have to lateralize the nerve and complicate things for the patient and for your own self. Now, lateralization nerve, I have done a couple of cases, but it's a fairly lengthy, fairly tedious procedure, and you have fair amount of bone buccally, so you can easily bypass the nerve, either buccally, as I have shown in 2 of my cases. In one case, I had, for the lady who had Parkinson's, I had done a lingual bypass, and for the gentleman who had a crystal kind of a mental foramina, we had done a buccal bypass there. So you don't need to lateralize the nerve at all. Why necessarily make things worse for you? And as regards the complications are concerned, yes, the patient could. It's a very, very technique sensitive procedure. You have the nerve which is being, you're creating a window, a slit, a slot into the buccal aspect, taking the nerve out of it and keeping it outside. So why unnecessarily going for all those procedures? That is where these implants have a plus, have an edge over other systems. Dr. Kalra, you want to add?
Yes, there is always bone present buccal to the nerve in the region of 7, like in the region of second molar, because nerve enters from lingula and then it stays lingual, that is close to the lingual cortical. And then the region of 8 and in the region of 7, we have almost 4 or 5 millimeters of bone always available. And the buccal plate at that region is quite thick. It's quite 6 to 7 mm thicker. So we can easily, bypass now at that point. And most of the times when you bypass, it's just like simple implant placement. So it's nothing big many times. So we come to know that we have bypassed the implant by seeing in the X-ray only, because we are doing in local anesthesia. So that way we are safer. If we'll go close to now, the patient will respond. As there is lots of bone available, buccal.
You do not give a nerve block, never give a nerve block for implants. We only infiltrate to sum it up.
Yes.
So that is why that makes the life more easier.
So we are not doing any lateralization or anything. We are just simply bypassing implant because our implants are sleeker. See, the main thing is our implants are sleeker. They have 2 mm of shaft. If we are doing with the help of BCS implant, so it has just a shaft of 2 mm and its fluids are of different diameter like 3.6, 2.7. Suppose even lesser bone is available, we can go for 2.7 mm diameter implant whose shaft is 1.8. So if the less bone is available, even then we can easily bypass and place implant. Then we can bend these implants into our prosthetically available position.
Yes.
So it's very easy. It looks difficult, but it's quite easy.
Thank you very much, sir. Moving on to the next question. This is a question from Dr. Gaurav. Kindly explain method 9 for upper canine bypass. How to approach the second cortical in method 9?
Okay. The method we tend to bypass the canine. Now, for this, we need to know the anatomy of the root. And plus, we also know that there is a fair amount of palatal bone or bone palatal to the root of the canine and the upper tooth. Now, while we are bypassing the canine region, we are aiming at the apex, maybe beyond the apex of the canine, so as to avoid any kind of a contact or inadvertent contact. Plus, you need to finger brace while we were taught how to extract teeth. If you recollect way back in, we were told to stand at a particular position, hold the particular socket area, and then put in our elevators or luxators. So moment we would realize that we have gone slightly astray, our finger brace would inform us that no, we should be distant from the area and we need to change our angulation. So similarly, while you're finger bracing this area, you would actually know where you're exactly going. So, and then you are aiming at the apex or beyond the apex of the canine. So and the choice of the implant should be such that you don't use a very wide-bodied implant. If you're using a BCS EX, you need to ensure that it is placed at a distance from the body of the canine. One. Secondly, for beginners, it will not be wrong if you maybe to start with, even though we do not advertise or advocate a CBCT, but for beginners, you can go in for a CBCT also. As far as I'm concerned, I would take CBCT only for academic reasons, for presentation purposes. But otherwise, yes, you need to aim at towards the apex of the canine, and in fact beyond that. And you must always have your finger brace both palatal and buccal, so that you know that you are not inadvertently damaging or traumatizing the canine in any which way.
Thank you very much, sir. Moving on to the next question. This is a question from Dr. Kabilan. What will be the occlusal scheme for full mouth rehab full mouth rehab cases using cortical implants?
It's a very, very long topic to talk of, but to answer it in short, you require a balanced occlusion on both the sides. You need to ensure that there are no anterior contacts, and your occlusion will only be from the 4, 5, and middle point of the 6. So we have various occlusal modalities for a class 1, for a class 2, and a class 3 patient. So we need to go into details of that. But by and large speaking, it is a balanced occlusion with on both the sides, with your main occlusion being on the 4, 5, and the 6. You do not want the anterior teeth to interfere, so there should be no anterior interferences. That means the canine to canine region should generally be left without interferences. And about the eighths, you must ensure that there is bilateral. You need to remove the eighths if they come into the line of occlusion. Firstly. Secondly, you must ensure that there is bilateral symmetry. You can't have your teeth present or implants up to the 7 or the 8 and one side and up to the 6 on both the sides. There is something called as an AFMP angle. So there are a number of things. It's a huge, very big thing. But all in short, the occlusal scheme will be from the 4, 5, and 6. The teeth, the occlusal pattern. Yeah, Dr. Kapil, you can add something.
Yeah, here we basically follow bilateral balanced occlusion, and where all the forces are supposed to be intrusive and no anterior contacts. So in short, and the concept is called supporting polygon concept. So it's a quite big concept to talk here, like it will need another session to discuss. The basic thing is we basically want all the forces to be intrusive and inside a supporting polygon, which is made by, we can decide by position of implants. So it's a long topic to be discussed.
Thank you very much, sirs. Moving on to the next question. Question from Dr. Aditya. How do you treat fracture of implants related complications for HT and diabetic patients or cardiac patients?
Okay. For fracture of implant, depending upon where it is fractured, generally, I would fracture an implant if I have not done the osteotomy properly, or if I am over talking it, if I have no control over my talking forces. And if you fracture it in the neck region, we do have something called as a B21 abutment to take care of that particular area. And because our implants are very, very well polished, so they can be easily retrieved should the need be. Even though he is a diabetic, you need to take a call there and then. You need to assess his blood sugar levels, and then go in and take a call to remove the implant as and when required. Even though it is a piece of titanium and it is polished, I'm not advising that you can leave it, but you need to weigh the pros and cons. If the medical condition, underlying condition, does not allow the patient to undergo a surgery there and then, retrieve it there and then, you can pend it later or even leave it there in a very, very rare instance. Again, the call is the clinicians and not the, and if you should you fracture it, that is.
Thank you very much, sir. Moving on to the next question. Although this looks easy and simple, but what are the absolute contraindications for corticobasal implants? I mean about the patient selection.
Nothing is easy. Everything is a learning curve. Each case, each patient, each case will be a learning kind of a thing. You need to get yourself trained, and the learning curve is endless. Dr. Stephen Hide, who is father of modern corticobasal implantology, he also claims to be learning. I am nowhere near him. I also am learning, and so are all of us. So coming on to the contraindications of patient selection, the only patient selection, that the contraindication that I could think of or I could advise you is somebody who is on IV bisphosphonates. You need to handle them with care. That could be one, maybe an absolute contraindication. Patients who are uncontrolled diabetics, who have no control on their diabetes, patients, you need to handle them with caution. They could be relative contraindication, even though we regularly plants with HB1AC, almost 8. I had mentioned a case, in fact 9 also, with fairly good prognosis. As regards the patient's follow-up, patient's availability on your require prerequisite scheduled time is very important, because you need to constantly assess the patient clinically, maybe every 6 months. You need to make, maybe 3 months, depending upon case to case. You need to make radiographic assessment, maybe a CBCT every year and a half, 2 years. Dr. Kapil, start karna chahoge aap?
And the patients who are psychic, like who cannot follow your instructions or medically challenged, if they can't understand your instructions, if they can't come to follow-ups because of their mindset or due to some mental situations, then better to avoid. Or sometimes I feel the OSMF cases where mouth opening is not possible, and patient need to open his mouth, to place implants. So you need to treat first OSMF. When mouth opening is comparatively fair, then we can put implants in that. So these are contraindications.
Absolute is bisphosphonate patient on IV bisphosphonates.
Yeah.
Thank you, sirs. Moving on to the next question. Question from Dr. Jyotsna. I had a patient who was borderline diabetic, had gone for immediate placement in #45. Implant became mobile after a month, maybe due to uncontrolled diabetic levels. I had left the implant there itself. How would have I moved further from here?
Doctor, depends. It's a very, very case specific kind of a case. If it was only 4-5, depends on the type of implant that you have used. Generally, if you're using a polished implant, it's always better to have 2 implants to splint them. So also your primary stability, the kind of bone you had, I'm sure would be having the mental foramina in its vicinity. So with the kind of anchorage that you took, the kind of implant that you put. So maybe if you can post me in my personal chat box, in my personal number that you've seen, maybe I'll be able to answer that question better, because this is very, very a case specific kind of a situation. So why it happened is very difficult for me to say without having going into the clinical details and radiographic aspects.
Thank you, Dr. Rahul. Dr. Jyotsna, I request you to kindly get in touch with Dr. Rahul on his personal handles. Thank you so much. Moving on to the next question. This is a question from Dr. Kumar Saurav. Does flapless technique leaves papilla around implant in lesser acceptable state than open flap implant placement technique?
Does flapless technique give papilla around the implant? No. Aesthetic wise, you need having a papilla is a very, very technique sensitive procedure, and there are various ways, various means, various procedures that you can have a decent papilla build up or around your regular implants also. So when you can do it that way, various techniques you need to that of course is beyond the prospect of this particular session. It's a separate topic by itself, aesthetics in corticovisual implantology. I have tried to cover, I've shown a case where this young girl who was in marriageable age, she's got a decent papilla building up, even though that is a very old picture. So no, you don't necessarily need to raise a flap. You can modify it, your approach towards the soft tissue, and you can get fairly acceptable and decent aesthetics and the papilla build up, even with corticovisual implants.
Thank you very much, sir. Moving on to the next question. This is a question from Dr. Kavya Shri. In severely atrophic edentulous maxilla and crossbite, how well basal implants can replace the conventional implant without the grafts and followed by prosthesis?
Severely, I'll just read the question again. How well basal implants can replace conventional implants? Okay, you need to treat the entire case as a whole always. And while you are handling a crossbite, you need to handle it both ways simultaneously. You need to balance the bite, balance the occlusion on either sides. I repeat, you need to treat the entire case as a whole. You cannot just raise the bite on one side and forget about the other side. So you need to have a bilateral approach while you are doing a crossbite. In one of my cases, I had shown an anterior crossbite wherein we needed to raise the jaws, raise the occlusion, the bite, and then jump the jaws from a class 3 to an edge to edge to a class 1 kind of a situation. Dr. Kapil, you have done a case recently, you will be able to add to this.
Sir, what you have said is absolutely right. We have to treat cases as a whole. And in case of cross bites, the cross arch splinting helps a lot. As well as, I will say, the cortico-basal system is better in such cases because these are this is a bone-driven system. Here, wherever bone available, we can place implant. Then we can bend accordingly into the prosthetically favorable position, so that up to some extent that cross bite can be managed by bending. And the other things which will usually help is cross arch splinting and the occlusal principle, like how your lab guy is fabricating. See, in supporting polygon, we explain in detail about such cases. This is a very common situation in atrophic cases, because during atrophy, the maxilla will maxillary
Contract.
resorption will be centripetal, and mandibular will be centrifugal. So in most of the cases, you will find maxilla is small and mandible is quite large. So
Yes.
answer to this lies in supporting polygon details, that how the prosthesis is supposed to made and how we are supposed to follow that principle. So
Fair,
it's a
fair,
long
fair.
topic, but can be
Yes.
explained very easily. I think,
Yes.
but this is
Yes.
not the right time to explain.
Yes.
Thank you very much, sirs. Moving on to the next question. Very quickly, we'll have to cover the other questions as well.
Yes. Yes. Please.
Question from Dr. Vijaya. How to avoid bleeding complications in pterygoid implants, and which other complications can take place, and how do we manage them?
The bleeding complications is relatively rare in that area, and in case, because your internal maxillary artery, which is a major matter of concern for all of us, that's one area where we could end up puncturing, and that could become a situation which will be difficult for us to tackle. Now, that internal maxillary artery is about almost 25 to 35 millimeters away from the area where we would, the superior most area where we would be engaging our implants. So for us to reach that far will be very, very difficult, because our implant drills are not more than 30 millimeters in length. And even if you go the entire 30 millimeters, you would barely be reaching the half of the area. So firstly, for you to have reached that internal maxillary artery is very difficult. Secondly, in case there is a bleeder, a microcapillary bleeder, and from there itself, maybe just a normal pressure pack could do. Or in case you find there is a minor bleeder into the osteotomy site, maybe you put in an implant itself, that itself will compress that area and ensure that the bleeding is taken care of. You could also, in case in the initial areas, maybe greater palatine artery, even if you go haywire, you could end up traumatizing that. That could result in a bleeding, which again, a pressure pack for a long should suffice.
Thank you,
sir.
sir.
I would like to add a little there. The other complication could be like hitting the lateral muscles which are attached to the lateral pterygoid. So in that case, there will be a trismus, and that will subside by itself in a matter of 21 days. So no need to do any major like surgery or something to.
One more thing, if I
cope up,
yes. Wherein you are going in for, you could end up fracturing the pterygoid plate because it's a very thin plate. So you need to be very, very judicious in while you're putting in your implant, firstly, and you need to take a call whether to bend it or not. Generally, it is not advisable to bend the pterygoid implants. So,
yes,
and even if you fracture it, you need to just leave it there for a while, and it heals on its own. So nothing that you need to do, except that you will lose upon the pterygoid, and your treatment modality, you'll have to look for other areas for distal anchorage.
Thank you, sirs. Quickly, we move to the next question. Sorry. The next question is from Dr. Kavilan. How will you verify the centric relationship of the prosthesis in single arch rehab, since we deliver it within 3 days? Normally, in full mouth rehab cases, we will wait for at least 1 month after giving temporary restorations to check the TMJ in harmony. But in cortical implants, how is it possible?
Okay, very good question. Very, very interesting question. I was waiting for this question for quite a while. Now, yes, no doubt, you're right. We'd have to wait for a longer while in our conventional implants. Initially, while we make the impressions, we follow the proper protocol. We give the patients the regular impressions. We take phase bore records. We would want to give the patient the anterior jig, just to ensure that he comes into his centric as soon as possible. And to cater for his TMJ problems, that how much of vertical we've opened, we initially, in cases where there's a total collapse of the arch, and depending upon following the misclassification of giving processes, we could decide upon whether to go in for a PFM or a hybrid processes. Invariably, in the initial time parts of the treatments, maybe for the first processes, in case we find the patient has got a totally collapsed bite and we anticipate that there could be some TMJ issues, we would generally go in for a hybrid or a metal fused to composite or a composite fused to metal kind of processes, knowing that the acrylic and composites are a lot more forgiving, and being softer materials, they can be manipulated easily and things done to suit our requirements.
Thank you for answering to the question, sir. Moving on to the next question. How to conclude a case with cyst tumor because due to chances of familiar recurrence rate? How do cortical implants work in these cases?
The call is of the clinicians in this particular case. You need to ensure that the cystic lesion or the cause is taken care of. Depending upon the type of cyst or type of tumor or that type of pathology you have, you need to take a call. These implants, because they are polished, they can go intracystic also, but you need to ensure that your entire the pathology is taken care of. Like the case which I showed, I ensured that the cyst was removed. I ensured that I waited for a particular period of time so that there is no recurrence. I waited for around maybe 6 months, had a regular follow-up on the case, did a CBCT, and then went in for the implants once I was sure that the things around there, the pathology there was taken care of. Mind you, I will just repeat, implants are elective procedures. They are not emergencies. So you need to take a call, and implant should be, it's a treatment modality. So it is important that we treat the underlying things first, ensure that the underlying problems are taken care of. If it is a recurrent cystic problem for any, there are a number of lesions which can recur, you need to take a call whether to go in for implants at all or not, because we would not want the patient's life getting jeopardized because of our treatment protocol.
Thank you very much, sir.
System. Yeah.
Thank you very much, sir. We take a few questions from the other social media profiles that we were live on. This is a question from Dr. Ashraf from Dubai. I have been using two-piece implants only because of the fact that I have heard a lot of negative comments about implant neck breakage in basal implants and one-piece implants. What is your take on this, and what would you advise?
I've been doing cortico-basal implants directly and indirectly from 2008 onwards. And in my span, the implant necks that I have fractured or that have come to my notice are generally because of the improper osteotomy. It is, again, it's not the gun, it's the man behind the gun. The bullet is meant to kill me. If it doesn't kill me, it kills the entire world. The purpose is lost. So it is the skill of the operator, firstly. And the implant neck generally would fracture as far as I'm concerned in my hands. I do a lot of them. I have done a lot of them in the past. It's been a learning curve for me as well. Will be if I am doing an under osteotomy and I am putting in and talking in an implant a lot more. So in case where you feel that the implant is going at with a difficult torque, you need to unscrew it, maybe modify your osteotomy, and then put in the implant. And the beauty of our system is that these being polished implants, the necks being longer, we can do a bit of like we do a crown lengthening kind of a procedure. We slightly do a crown lengthening here, or we do create a small little trough in the bone and in the soft tissue, and we can utilize this area to put in a B21 abutment and even utilize that implant which is broken. So generally, implants will not fracture routinely, not in occlusion. They will only fracture, as I'm concerned, that I can think of, or where there is overload, excessive overload. Patient is constantly eating only from one side. That also will happen because if there is no regular follow-up. It will happen to the gentleman who was a pancher in my case. It could happen to him if he started using on a unilateral side of chewing. So that is where your follow-ups are very important. However, I don't think I've had many cases wherein we've had fractures post-op or in usage. Very, very rare. But that again is operator dependent. You need to have constant follow-ups and radiographic analysis of the case. So if
even I
problems, you can share them with me. I'll see how I can help you. Yeah, Dr. Kapil.
Yeah, even I haven't seen a single case of fracture after the prosthesis is loaded, because all the load is being shared by the number of implants, like 10, 8 number of implants. So this usually happens when only single implant is taking all the load. But in our case, we are doing immediate splinting, so all the load will be transferred to all the implants. It only happens when you over torque or because of inexperience, or and still there is an option of B21 abutment, and you can immediately restore that if the neck fractures. So it is quite simple, quite easy to handle. If the guy who's asked the question is not doing because of that thing, I think he should immediately start doing this system.
Get your basics clear. You can ask us. We can help you in whatever way possible. But if you're doing it, if you're aware of this, please go ahead.
And Dr. Rahul can show you such cases also using B21. No?
Yes,
See his muscles.
Yes,
he applies lots of forces.
Yes.
Thank you very much. So last two questions because before we wind up the session. This is a question from Dr. Akshay Shah. We got this on YouTube. So which jaw should be restored first? That is the first question. And the second question is, which protocols should be used for inferior alveolar nerve bypass?
Which jaw should be done first? Well, it's the operator's choice. Generally, patients are quite a bit of a dilemma and kind of a bit of a problem with the lower denture. The lower denture generally is the one which creates problems for them. And in my experience also, I've had patients who come for replacement for the lower jaws first, lower jaw only, and after being thoroughly satisfied with the lower jaw implant supported processes, have they come back for the upper ones. However, it is the operator's choice or the patient's outlook. Whichever jaw he wants can be done. I would go in for the lower one first for patient satisfaction, in case it is a totally edentulous kind of a thing. Or rather, we should do both sides simultaneously so that we can have better occlusal scheme and better comfort to the patient.
Thank you very much, sir. Last question before we wind up the session. This is a question from Dr. Nitish. I have heard if one basal implant fails, we have to remove all the basal implants, especially in a full mouth case. What is your take on this?
No, I would not agree on that because our implants, we always tend to over-equip our maxilla or the mandible. We could easily do with 8 implants, wherein we put 10 in the upper jaw, which is a regular protocol. In one of my cases, in the lower jaw, I have put 8 implants because the gentleman was a very, very robust person, athletically built, and had a big jaw. So I thought I could even put 12 implants in the lower jaw. So the take is yours. So if you are over-equipping the jaw, even if one of the implants say fails for any reason, which generally should not, generally the cause would be an occlusal cause. It could be because of the occlusal loading that or overloading that has happened or occurred, or maybe for some reason while the operator was placing the implants, he must have missed the cortices or missed the target area. So even if that happens, because the implants are fairly over-equipped, in a worst come worst scenario, you could just maybe, and if you feel it is loose and it is ailing, you can take a call. You can replace the entire bridge and put a new, or else there's that particular implant which is mobile. Generally, the implant which could trouble you would be in the maxillary sinus area, which over a period of time, in some patients who have breathing problems, where the sinuses could get pneumatized, there maybe you could just cut the neck of the implant and remove the entire implant in totality with the processes in place. So no, this is not a fact that if one implant fails, others will follow suit. No, this is not a contagious kind of a problem. And generally, in my experience, the moment you look into the occlusal aspects and look into the cause and treat the cause, things will reverse very well.
Dr. Kapil, would you like to add?
Yeah, because in our system, we are doing sanitary prosthesis in posterior. So you always have a space to cut the implant from the neck, and you can take it out easily. If only one or two implants, if you think they are ailing. Most of the time they are not ailing. It is because of occlusal overload osteolysis, which can be rectified
Reversed.
by just surgical adjustments. But still, if you feel, you can easily cut and remove one implant. No need to remove the full prosthesis. So it's just a practical, experience thing. So it can be easily done.
Thank you very much. Thank you very much, sirs. Thank you, Dr. Rahul Vaid, Dr. Kapil, for the lovely session. With this, we come to an end for the fantastic presentation. Once again, on behalf of Team Dentist Channel.online, I'd like to extend my gratitude for the amazing presentation that you gave and for the houseful presentation that we had. A big thank you to all the participants for your lovely messages. That motivates us and that keeps us to going. Friends, do not forget, 3:30 p.m. today, Dr. Ritul Agarwal will be live on dentistchannel.online. Thank you very much. With this, we come to an end. May you all have a good day.
Thank you so very much. All of you, please stay safe, stay good, and practice corticobasal implantology. Thank you so very much. I'm grateful to Dentist Channel Online. Thanks a lot, Ruben and Siddiq. And thanks a lot, Dr. Kapil, for being there. Thank you so very much.
Thank you very much, sir. Thank you very much. Please have a good day.
Thank you. Thank you, buddy.